Some of my girlfriends were recently asking me about hormone replacement therapy and what they should do about it because we're all getting to be that age. So I wanted to kind of start from the beginning. And for me, the beginning was, well, it certainly was before this, but this was for me kind of the beginning of my hormone journey, I guess I would say. I was about 30 years old and I was having my own hormone problems. I was just about finished with my OBGYN residency. And I was finding that I was more and more often on the couch like this. I was tired all the time. I had actually lost my sex drive. And more every day, I was finding that I was more and more anxious to the point that I found it hard to even do my job as an OBGYN. I was really nervous when I had to do deliveries, when I had to go to the operating room, and I had no idea what was wrong with me. I checked the usual things that most OBGYNs would check, but beyond that, I had no idea what was going on. So I'll leave it at that for now and tell you a little bit more later. So I want to welcome you to this seminar tonight. I want to talk about why I think menopause is a problem that we should pay attention to. I want to talk about why bioidentical hormones are safer than non-bioidentical hormones. I want to tell you why you should consider hormone replacement therapy. And I want to tell you why you should decide now if you're going to use hormone replacement therapy, why timing is of the essence. So this is something that not a lot of people talk about, but it was the conclusion of a study I had read on the dangers of menopause, basically. And the bottom line is that hot flushes are the canary in the coal mine. It's become clear that hot flushes are a signal to the body that something's wrong. They're way more than just an inconvenience. So studies have shown that hot flushes are what we call vasomotor symptoms. And by the way, when I say hot flushes, it's hot flashes. It really doesn't matter. They're the same thing to me. Some people differentiate, but I don't think it makes a difference. Anyway, the bottom line is that women with more hot flushes have more cardiovascular disease. They have increased signs of atherosclerotic plaques. Those are those things that it says there, increased CIMT and decreased FMD. These are early signs of plaque. And basically in the journal Circulation in around 2008, they started saying that, we're noticing that women with hot flushes have more early signs of atherosclerotic plaque than women without hot flushes. So then there have been multiple studies since then that associate hot flushes with higher blood pressure, higher lipids, meaning cholesterol, and more insulin resistance, which raises your risk of diabetes. Also something called decreased heart rate variability, which is a sign that goes along with heart disease as well. Then they found brain issues. There were increased what they call white matter intensities. And these are associated with a dementia that happens from basically vascular disease in the brain. And then of course, osteoporosis. A lot of us know that women with more hormone deficiency have more osteoporosis. So all of these things have been found to be associated with women who have more hot flushes. Now, just because you don't have hot flushes doesn't mean you don't have these things going on. But what I wanted to do is link for you the fact that our signs that we're feeling of menopause are not just inconveniences. They're actually signs of silent things that are going on in the body, in our brain, in our bones, in our cardiovascular system. So hot flushes are essentially an alarm. That's something that should be waking you up and making you pay attention. And it's not just hot flushes. It could be lots of other things. So these are some of the most common medical problems that I find that get treated with all kinds of different pills, anything from a birth control pill to a sleeping pill to a antidepressant, etc., on and on and on. But a lot of them are really, all of these on this list could really just have a hormonal cause. And I prefer to give women the hormones back that they've lost. So what are hormones exactly? Hormones have become in some ways such a dirty word. I want you to understand really what they are. They are naturally occurring in the body. They're your body's messengers, and they help take the signals from one area to another, particularly from your brain to the rest of your body, also from the rest of your body back to your brain. And particularly, of course, what we're talking about here is from your brain to your ovaries. And your ovaries, once you go into menopause, aren't able to answer as well as they would have before. So how do hormones work? One of the ways that they work, the most common way that they work, is hormones have to enter the cell and they have to bind to a receptor. And you can see when you look at the picture that hormone B is circular and hormone C has some rectangles. And for a hormone to fit into its receptor, they have to have an identical formation. So they kind of fit together like a lock and a key. And this is the issue with hormones that are exactly the same as what's in our body naturally, which for convenience, I call bioidentical. That means exactly the same chemical compound as we have in our body naturally, versus non-bioidentical hormones. And a lot of hormones that are available to women are non-bioidentical. And we're going to spend some time talking about the difference because, as you saw in the last slide, if the hormone is not identical in its structure, it's not going to bind properly to the receptor. And that means it won't have the same action in the body that the identical hormone would have. So bioidentical hormones. Some people call traditional hormones or non-bioidentical hormones, some people call them synthetic. I don't call them synthetic because all hormones, even bioidentical hormones, have been synthesized from something. And they are actually synthesized mainly from soy and yam sources, which I don't think makes them any more natural necessarily, but some people feel better about that. But they make them into hormones that are exactly identical to what's in your body. And bioidentical hormones, this will surprise a lot of people, can be obtained through compounding pharmacists, like you may have heard of, but they can also be obtained through CVS or Walgreens. There are bioidentical hormones that are regular old prescription pharmaceuticals. And we're going to talk about some examples of those at the end of this talk. So what are some of the symptoms of menopause? Some of you may be already having some of these, and some of these are symptoms of perimenopause as well. And perimenopause is, of course, the period surrounding menopause. And it can even be 5 to 10 years before menopause. So I guarantee probably most of the women listening to this are in this period of time and may have some of these symptoms. And some of them may surprise you. Like most women know they're going to get hot flashes, or they might get hot flashes, and they might have trouble sleeping, and they might get moody. But a lot of women don't realize that they're going to get vaginal dryness that may cause pain with sex. They're going to some women get itching, and they can tell when their hormones are low actually by itching that happens, especially from dry skin. Joint pain is another one that I find when I give women hormone replacement, their joint pain gets better and they say, wow, I didn't even realize that I had this joint pain from my hormone deficiencies. So there are lots of different symptoms, as you can see, of menopause and perimenopause, and a lot of them will get a lot better with hormone replacement therapy. So a lot of people that I talk to, a lot of women my age, they say to me, well, I've heard hormones aren't safe, so I'm not going to take hormones. So I want to talk to you about the risks of going without. The Nurses' Health Study was an observational study of almost 30,000 women, and they're all nurses. They've studied them for many years, and there were over 16,000 women who had their uterus and ovaries removed, not for cancer, but just for reasons like fibroids or ovarian cysts or whatever. And what they showed in those women was that they had a higher cause of all-cause mortality, so a higher risk of dying from anything than other women. They also found that their risk of fatal coronary heart disease was higher, and also their risk of lung disease was higher. So we have to think about what's the risk of going without. So something I think is kind of ironic is that hormone replacement therapy is absolutely recommended by all the hormone societies for women under 40 who lose their hormones. And they recommend this because they say there's an increased risk of osteoporosis and heart disease. And so we need to give those women hormones until when they would go into natural menopause. So from like 40 to 50, let's say. But the question in my mind is, why should this change when women lose their hormones naturally? Why should we let them go without? And we're going to talk about some of the benefits of having hormone replacement therapy. And I hope I'll explain to you why we got scared off of it and why that was really just a tragedy. So estrogen is one of the most important hormones, but there are three main hormones we're going to talk about. And estrogen has, believe it or not, over 400 functions in the female body. It affects your mood, your memory, your structure, meaning like your bones, your joints, connective tissue. Estrogen protects against heart disease, and it maintains your bone and helps prevent osteoporosis. Progesterone balances the effects of estrogen. It has a calming effect, and it's really good for mood. It has some benefits to the cardiovascular system that we'll chat about a little bit. It's beneficial for the brain and the nervous system. It helps balance blood sugar, and it has influences on thyroid function. And progesterone, in addition to estrogen, helps with bone. And then testosterone, which is my favorite, I have to say. Yes, we women have it too. And we naturally have more testosterone even than we have estrogen in our bodies. Testosterone gets produced by our ovaries and our adrenal glands and other tissues. And testosterone helps with energy, memory, mood. It helps with sex drive. It helps us keep and gain muscle, helps us lose fat. And again, it helps protect our bones. So testosterone has some good important functions for women as well. So now we have to reverse all the way back to 2002. So I finished my OBGYN residency in 2000. And at that time, my chief of OBGYN told us that if we didn't prescribe hormones for women and they had a heart attack, that we should be successfully sued for malpractice. So in other words, he was trying to encourage us to prescribe hormone replacement therapy for every woman we saw, or at least document the fact that we had offered it. And that was how strongly it was believed before 2002 that we should give women hormone replacement therapy for their hearts, their bones, their brains. Then in 2002, this WHI study was halted prematurely. WHI was the biggest study on hormones that's ever been done. It's like $1 billion study. And what they showed was only after 4 years of hormone replacement therapy that women were having an increased risk of breast cancer and heart disease and stroke. So they canceled the study, or at least part of the study. So there were multiple problems with the WHI study, but one of the biggest was that the average age of women in the study was 65. The average age of most women going on hormone replacement therapy is around 51, which is the average age of menopause. So that was strange and didn't match up. And so their population wasn't representative of the population that they should have been studying. So that was one of the big problems with the WHI. And we'll talk about hormonal timing, and the age thing comes back into it in a little bit. So one of the things for you to know about the WHI and breast cancer, and once you know this, you may be ahead of your own gynecologist, because when I teach other doctors and I ask them, how many of you believe that estrogen causes cancer, at least 50% of the room raises their hand. And that always shocks me, because I figure, since I'm asking the question, that they would probably be suspicious that I was saying something that I was believing might not be true, but at least 50% of the room raises their hands. And these are people who are at a conference to learn how to prescribe hormones to women. Well, the interesting news is that from the study in 2002, one of the things we learned is that estrogen actually doesn't cause breast cancer. So there were two arms of the WHI study. In one arm, women got estrogen by itself. In the other arm, women got estrogen in combination with an artificial form of progesterone called Provera. It was only in the combination arm that women had an increased risk of breast cancer. In the arm where women only got estrogen, they actually had a 20% decreased risk of breast cancer. So estrogen only was shown to decrease the risk of breast cancer in the largest study that was ever done of hormone replacement therapy. So if anybody ever tells you again that estrogen causes breast cancer, it doesn't. And the biggest study that got everybody all freaked out showed very clearly that estrogen does not increase the risk of breast cancer. What it also showed was when you combine estrogen with Provera, it does increase the risk of breast cancer, and it increased at about 28%, which was significant. And that's what got everybody freaked out. But unfortunately, everybody just got freaked out and didn't get the real information. So one of the things to keep in mind as well is that the WHI only studied one type of hormone replacement therapy. They looked at the type of estrogen they looked at is called Premarin. And then they looked at it in combination, like I said, with an artificial progesterone known as Provera. So neither of these were bioidentical at all. Premarin is actually estrogen from horse's urine. It's actually Premarin is the name of it, and it stands for pregnant mare's urine. That's what the name Premarin means. And so the estrogen in Prempro is Premarin, and that was not shown to increase the risk of breast cancer. And then the combination of estrogen and Provera did increase the risk of breast cancer. But the problem was they should have expected this. There were studies that predated the WHI study, multiple studies, as you can see up on the screen, where estrogens were combined with Provera, and there was an increased risk of breast cancer. So the WHI, we just said it increased it from 26 to 28%. The Million Women study looked at the same thing, and the risk of breast cancer was increased. The E3 and EPIC cohort, which is a big European study, showed an increased risk. The Finnish Cancer Registry in Finland showed an increased risk. But interestingly, estrogen alone did not increase the risk of breast cancer in most of these major studies. And in the largest one ever, the WHI, like we talked about. So this one is that European study, and I wanted to highlight it because they did study 80,000 women over the course of like 10 years. And one of the things that they did study, this is in France, and in France, they did use bioidentical progesterone some. They used the artificial, but they also used the bioidentical. And what they showed was that the same as WHI, when you combined estrogen with an artificial progesterone, the increased risk of breast cancer happened. In this study, it was 69%. But in a study, in the same study of women who took estrogen combined with bioidentical progesterone, there was actually no increased risk of breast cancer, and there was a slight decreased risk of breast cancer for the women who took a combo of estrogen and progesterone. And this is a pretty big study, 80,000 women over the course of 10 years. So there's a lot of information that's coming out since the WHI study that's very reassuring about hormones. Here's another one. This was a 2016 meta-analysis, and a meta-analysis is considered to be the highest level of evidence that we have in scientific studies. So this looked at over 86,000 women. Their mean age was 59, and they were followed from anywhere in the studies, depending which study, from 3 years to 20 years. And progesterone as a hormone therapy was associated with a 33% lower breast cancer risk than the artificial progesterones. So it's important to realize that it's that artificial progesterone that caused the majority of the problems that we know about hormone replacement therapy. So not all hormones are the same. I figured this might appeal to some of my friends since we love to drink wine together. Not all things are like the other, right? So artificial progesterone, Provera is one of the most common ones, increases the risk of breast cancer when added to estrogen. It's like adding gasoline to, I wouldn't even say a fire, because estrogen's not really a fire, but it's like adding gasoline and lighting a match by adding Provera to estrogen. Bioidentical progesterone, on the other hand, does not increase breast cancer risk. And if anything, it calms it, it decreases it. So unfortunately, back in 2002, everybody, the media, gynecologists, women, they threw the baby out with the bathwater. They said, well, this one particular type of hormone replacement therapy causes breast cancer, so we shouldn't take any hormones. And that's crazy, because that study did not prove, and in any way, shape, or form, that all hormone replacement therapy is dangerous. And since that time, now we're 20 years in, we have a lot more information that's telling us that hormone replacement therapy can be taken safely and effectively. So we have much newer statements from 2017, the American Association of Clinical Endocrinologists. They posted an update to their clinical practice guidelines, and they said micronized progesterone, which is bioidentical progesterone, is safer than other progestins or artificial progesterones like Provera. They also said transdermal estrogens, when compared with oral, may be considered less risky for clots and strokes. So that was the other issue they saw with the WHI study. In the women who were taking the estrogen, who had a decreased risk of breast cancer, they ultimately were shown to have an increased risk of clots and strokes. And ultimately, it seems that the reason why was because they were taking the estrogen as a pill. And we'll talk about this in a little bit, but it turns out that taking estrogen through the skin is much safer than taking estrogen as a pill. So I wanted to highlight a little bit from the North American Menopause Society, their position statement that came out in 2017. Basically, they say hormone therapy remains the most effective treatment for hot flashes and the genitourinary syndrome of menopause, which is vaginal dryness, increased urinary tract infections, things like that, and has been shown to prevent bone loss and fracture. They say treatment should be individualized to identify the most appropriate hormone therapy type, dose, formulation, route of administration, and duration of use. And I highlighted duration of use because for a long while after the WHI study, they said that we should only use hormone replacement therapy for the shortest time possible. And back in 2014, the American College of OBGYN got rid of that, and they said it should be individualized. And now NAMS is backing that up, that we should individualize the therapy and that we don't automatically have to stop it just because a woman has turned a certain age. This was a follow-up from the WHI. So that big study of Prempro, really interestingly, even though, so the women were on Prempro for 5.5 years, and the women who were on estrogen alone were continued for 7.2 years. So all these years later, it turns out women who stopped the therapy, neither therapy, Prempro nor estrogen alone, was associated with an increased risk of overall mortality. And with the estrogen by itself, remember I told you estrogen decreases the risk of breast cancer. Well, the women who had estrogen by itself, their risks of dying for any reason, of dying from heart disease, dying from breast cancer, and dying from Alzheimer's were all decreased. To me, it's kind of sad that they stopped the therapy. So more recently, this study just came out at the end of last year. The Long Island Breast Cancer Project's been going on for a really long time. People who are from New York might know that Long Island has a pretty high risk of breast cancer, and nobody really knows why. But they study a whole bunch of women from Long Island who have breast cancer. And in this particular study that was published in the International Journal of Cancer last year, they showed among women in the study who had breast cancer, use of hormone replacement therapy was associated with a lower risk of dying for any reason. It was associated with a lower risk of dying from breast cancer. That surprises a lot of people. And use of hormone replacement therapy was associated with a lower risk of dying from heart disease. And we all know that heart disease is, well, we may not all know, but you should know that heart disease is the main killer of women, not breast cancer, actually. Breast cancer is a big killer of women, unfortunately, but heart disease is much bigger. And but with in women who had breast cancer who also had hormone replacement therapy, they had a lower risk of dying from any cause from breast cancer and cardiovascular disease. So progesterone, I want to talk more about benefits of progesterone in women because I've been talking about how this artificial progesterone Provera is very bad and increases the risk of breast cancer, but I want to talk about some of the other benefits besides protection from breast cancer that progesterone has. So it has cardiovascular benefits. It actually decreases bad cholesterol. It decreases blood pressure. It decreases plaquing in the arteries, and it decreases clotting, and it relaxes coronary arteries. So that's all very healthy stuff for our cardiovascular system. Another thing that's kind of interesting is that estrogen has always been known to improve total cholesterol and improve good cholesterol and bad cholesterol levels. Unfortunately, Provera makes all of those parameters worse, but progesterone does not. Progesterone doesn't negate all of the positive effects of estrogen. It actually improves them even further. So yet another reason why Prempro was not the model therapy to study and certainly shouldn't make us throw the baby out with the bathwater. Then there's brain health. Progesterone is really good for our brain and the central nervous system. It's been shown to improve outcomes after stroke, after traumatic brain injury, and it probably decreases the risk of Alzheimer's as well. Artificial progesterones like Provera have all kinds of side effects. And these are some of the side effects you'll see with birth control pills because the artificial progesterone that's in birth control pills is actually pretty similar to Provera. And you see some women get hair loss, they have trouble sleeping, they get more irritable, they lose hair, etc. But natural progesterone, one of the best things about it, one of the things that women love about it is that it helps them sleep better and it causes them to be calmer. It also helps them with water weight and even increases metabolic rate, which we all could use with weight loss, right? So progesterone has a lot of benefits that the artificial progesterone doesn't. And that goes way back to, like I said, they don't bind to the receptors properly if they're artificial, but if they're natural, they bind to the receptors the way our hormones always have bound to the proper receptors, just like when we were teenagers. So briefly, I want to talk about estrogen's 400 functions I mentioned. It helps to protect the brain and it helps to protect the bones. Vaginal estrogen treats vaginal dryness, painful sex, urinary tract infections that get more common with menopause. Estrogen protects the heart and it protects us from new onset of diabetes. Another thing I know that will be near and dear to a lot of my friends' hearts is that menopause can cause weight gain, especially that dreaded belly fat. Hormone replacement therapy increases lean body mass, meaning muscle, and reduces waist circumference and abdominal fat. So I'm sure a lot of people probably want to take it just for that. Now, I'm not saying it's the magic weight loss formula, but it does help make the things that you always did in the past work better again. Because I know a lot of us find that when you go into menopause or perimenopause, the stuff you used to do to lose weight just doesn't work anymore. And it's because your hormones are off. So this is probably the most important thing I'm going to tell you. The timing of hormone replacement therapy is critical. This is one of the big things we've realized since the WHI. So this goes back to the fact that we studied older women in the WHI. The average age of the women was 65. But what they found when they went back and they reanalyzed the data and they looked at the women who were ages 50 to 59, they showed more benefit from hormone replacement therapy than they did from the older women. So now there's been multiple studies of this timing window, and I'm going to talk a little bit more about it than just this slide, but I want you to know that estrogen and hormone replacement therapy in general may have a lot better benefit if you start it within the first 6 years of becoming menopausal than it will later on. So if you just wait and you say, I don't feel like deciding this now, it's too much, whatever, well, you may really miss the boat because once you're 6 years out from your menopause, you're going to have much less benefit in the cardiovascular system, in insulin resistance, which is risk of diabetes, in your skin, so wrinkles, your bone, your brain, and of course, even weight. All of those things are going to be much better. You're going to get much better benefits from hormone replacement therapy if you start it earlier. So this is one of the trials that showed us this in 2013. It showed the critical timing window, and they looked at much younger women on purpose because of the WHI study and knowing that those women were too old. So they looked at women who were between 42 and 58 years old, and those women were only menopausal between 6 months and 36 months. And what they showed, they gave the women estrogen with micronized progesterone, and micronized progesterone is bioidentical progesterone. So the estrogen treated women had decreased new coronary artery calcium compared with women who didn't get hormones. So what is coronary artery calcium? Basically, they do a CT scan and they look at the arteries in your heart to see whether they have calcium buildup. And what they showed was the women who got estrogen replacement therapy early in their menopause had a decreased amount of calcium in their heart compared with women who didn't get hormone replacement therapy. And here's another study that showed something very similar. This one's called the ELITE trial, and ELITE stood for early versus late. What they did was they got two groups of women. They got women who were menopausal less than 6 years, and then women who are more than 10 years into their menopause. And they gave them estrogen therapy, and they gave them vaginal progesterone, but they still gave them bioidentical vaginal progesterone, which is a safe way to give progesterone as well. And so they gave some women the therapy and the estrogen plus progesterone, and then they gave some women placebo. So they had young women on therapy and young women on placebo, and then they had older women on therapy and older women on placebo. And they were looking again at that coronary artery calcium score, and they looked at another marker for arterial plaque. What they found was the women who got early treatment had less increase of plaque than women who didn't get any treatment in the early group. They also showed that the treatment group of the younger women who were earlier in their menopause had more benefits than either of the older women groups. There wasn't a huge difference in older women who got therapy or older women who didn't get therapy. And this is considered kind of one of the hallmark studies to prove that this whole timing hypothesis, the timing of menopause therapy, is critical, because the older women kind of missed the boat. It didn't hurt them. That was the good news, because in the WHI, they actually showed that it hurt them. Women who waited to be on hormone replacement therapy and then went on the, what I would call bad therapy, the Prem-Pro, they had an increased risk of heart disease. When they used bioidentical, like in this study, there was no increased risk, but there was no decreased risk. So the older women didn't get the same benefit as the younger women. So that's why I say timing is of the essence, and you need to decide if you're going to try hormone replacement therapy sooner than later. And I would encourage your friends to do the same. So then testosterone. Testosterone's my favorite, like I said, and I will tell you very shortly why. So some of you know I wrote a book called The Sex Drive Solution. So you know that you might figure that that's linked somewhere, because of course, the first thing, testosterone increases sexual interest, but it does other things too. Testosterone helps with energy, memory, mood. Testosterone actually helps women with their emotional shield. So it makes you feel more in control of your emotions and less like crying for no apparent reason. It also even helps with skin sagging. So I know a lot of us are interested in that, and it helps with mood. It acts like an antidepressant. So symptoms of testosterone loss, some that might surprise you, like saggy skin, thinning and dry hair. Most people think testosterone is not good for your hair, but it is pretty good for your hair. Women who are, of course, feeling like they're gaining fat, losing muscle. Just fatigue itself could be a sign of low testosterone in women. I know you hear about low T in men, but there's low T in women too. So what about causes of low T? So this is basically going all the way back to that picture I showed you. from when I was like 16 till when I had my first baby, and then between my two babies, I was on birth control pills the entire time. Birth control pills have the unique ability to block testosterone. That's one of the reasons they're so good for decreasing acne in young women, because some young women overproduce testosterone. And so the birth control pill is really good at bringing that down and decreasing their risk of acne. But what about women who don't have low testosterone? Who don't have high testosterone, rather, like women like me. So it turns out our pool of testosterone decreases as we age. And when I say age, at a very young age, between the ages of 18 to 34 is when we have our biggest drop in our testosterone levels. So being on the birth control pill in your late 20s and your early 30s can lower your testosterone that's available to bind to its receptor. And that causes fatigue, loss of interest in sex, and even loss of confidence and basically anxiety. And those were the things that I was suffering from in my early 30s. And I had no idea, because you know what? They don't teach GYNs to use testosterone in women. And it's really unfortunate, and it's a tragedy. And I'll talk a little bit about why you should feel a little safer about using testosterone therapy. So this was a study way back in 2009, when there were some testosterone studies in women, and testosterone was considered safe in the breast, in the uterine lining, and it actually might decrease the risk of breast cancer. And there's another slide that I have on that. And there are no adverse cardiovascular effects with testosterone in women. So testosterone, like I said before, I mentioned this briefly, is the most abundant. Well, I said we have more testosterone than estrogen, but it's also the most abundant hormone in the entire female body. And like I said, we have our biggest drop between the ages of 18 and 34, and then it just slowly goes down as we age. Menopause doesn't really do anything to our level unless we have our ovaries removed. Having our ovaries removed causes a big drop in testosterone, because the ovaries will continue to make testosterone even after menopause. And that testosterone is very supportive of women, even if it's smaller than it used to be. It's much worse when they have their ovaries removed. But unfortunately, in the US, we don't replace testosterone in women. In England and Australia, they've used it for a long time in women. And testosterone and androgens is the class of hormones that testosterone belongs to. We have androgen receptors throughout the entire body, all of those different tissues that it lists on the slide there. So we have androgen receptors everywhere in the body. Our whole body needs testosterone to function, and to not replace testosterone is really, in my opinion, is doing women a disservice. And my life would have been a lot worse had I not started replacing testosterone in my 30s. So I've been on testosterone replacement therapy for, I think it's about 17 years now, and couldn't be happier that I did that, because it helped me get back my energy, my confidence, my sexual function, and just, I would say, my mojo in general. So there are a lot of myths around testosterone, even with GYNs. I was taught not to prescribe testosterone because it would do all these terrible things. It would cause horrible side effects, and that women would be miserable, and that the side effects would be irreversible. But it's not even true. So a lot of women, maybe 10% or less of women will experience a little bit of unwanted hair. So yes, I do get a few little chin hairs. A lot of women who aren't on testosterone tell me I get them. They say, oh, I get those anyway. And most of them say that it's no worse on testosterone replacement therapy. And most women, even if they do see it, maybe it's a little bit worse, they say, I feel so much better on testosterone. I'd rather just pluck out the few hairs. It's fine. But it's very, very rare for women to have serious side effects. And I would add that the most common serious side effects I see with testosterone when women who've been treated by other practitioners come to me is from practitioners who had very little studying, training, or experience. So estrogen and progesterone therapy are pretty easy for most OBGYNs. For testosterone, if you choose to go that route, I would encourage you to seek out somebody who knows what they're doing with testosterone therapy. So adverse effects on the heart, are there any with testosterone? The overwhelming amount of evidence shows that testosterone is actually probably protective for the heart. And a 2019 meta-analysis, and like I said, that's our highest level of evidence, showed no increased reporting of cardiovascular events in women on testosterone therapy. And that was published in 2019. So that's a pretty recent study telling us that cardiovascular disease in testosterone therapy in women is not a concern. So this is one that I hear commonly. Women worry that it's going to make them more aggressive. Actually, it's completely the opposite. Most women who I put on testosterone replacement therapy tell me they feel less irritable and less anxious on testosterone. And like I said, testosterone acts like our emotional shield. So most of us feel like we could use more control over our emotions at perimenopause, and testosterone really helps with that. Liver damage. Liver damage was associated with a prescription type of testosterone called methyl testosterone. Again, it's a non-bioidentical form of testosterone, and that non-bioidentical form did increase the risk of liver disease. So that should not be taken. And that's the only prescription form of testosterone available in the US for women, unfortunately. So don't take methyl testosterone. So testosterone and breast cancer. Androgens, male hormones, basically, that's the category that testosterone falls into. They are usually shown in studies to protect the breast. Basically, while estrogen causes proliferation of breast tissue, testosterone does the opposite. It's anti-proliferative, and it inhibits breast cancer cell growth. So we think that testosterone is very safe for women at higher risk of breast cancer. So I want to get to the stage where I tell you kind of what you can do. So I tried to make this very simple, just to give people some options to think about. So the simplest option, in my opinion, is to go with the Vivell dot patch, which is a bioidentical estrogen patch that is available through your regular pharmacies like CVS, Walgreens, whatever. So that patch for estrogen delivery, because it's through the skin, not by mouth, and then micronized progesterone. And that's the bioidentical form of progesterone. So the Vivell dot patches for estrogen are very convenient. When I say Vivell, that's just the brand name, by the way. Most of the pharmacies will probably give you a generic, and it would say estradiol. Estradiol is a bioidentical form of estrogen, and it is the most widely studied bioidentical form of estrogen. So that's the one I would recommend. And by the way, I personally take the estradiol patch myself, and I change it twice a week. That's what's recommended. It sticks really well. It almost never comes off. No, showering, swimming, it like never really comes off. The glue is very sticky. That's probably one of the issues with it. If you had one, I just use coconut oil to rub the glue off, but on rare occasions, some people react to the glue, but very few people react poorly to the patches. So it delivers steady levels of bioidentical estrogen that has been shown to have all of those great benefits that we talked about. There are multiple doses available, but even if those doses don't work, I actually have women sometimes cut pieces of the patch off to customize the dose even a little further. So you might be sitting here saying to yourself, but I don't want to use a patch. And then one of my friends told me that their friend is using a mist, which is like a spray. So yes, there's a prescription mist. There are multiple other ways of getting estrogen through the skin that are bioidentical, because as long as they're estradiol, they are bioidentical, and they're available through your gynecologist. So you might be sitting here saying, though, I want to take a pill. Well, unfortunately, the pills were shown to do negative things in terms of clots and strokes. So they increase the risk of clots and strokes because they increase clotting factors in the blood. They also increase the risk of cardiovascular disease because they increase cardiovascular inflammation, and they increase triglycerides. And there might even be a relationship to increased blood pressure. So the good news is, though, in all of these years since 2002, there have been many studies of transdermal estrogens, meaning estrogens that go through the skin, and they show that they do not cause these negative changes. So you're definitely safer with the transdermal estrogens. So what about progesterone? Micronized progesterone is the commercial pharmaceutical name for the bioidentical progesterone. It has to have progesterone in the name. So Prometrium is the brand name of this micronized progesterone. It only comes in this one pill, and it only comes in 2 doses, and it comes in peanut oil. So for anybody who's allergic to peanuts, they can't take the commercial kind. You can get progesterone easily from compounding pharmacies to be compounded in other types of oil. For instance, olive oil is one of the common ones, but there are other oils that they do it in that are less allergenic than peanuts. And they can make them in whatever dose is right for the woman. Like for me in particular, I actually take right in the middle. I take 150 milligrams every night. So it's between 100 and 200, and I wouldn't want to not take the right dose. Unfortunately, that's all that's available from your Walgreens or CVS pharmacy, but your gynecologist can write a prescription for compounded progesterone in whatever dose is needed. In menopausal hormone replacement therapy, though, if you're taking estrogen, you also need to take progesterone at least 100 milligrams a day if you have a uterus. Now, that's a whole other story that I'm not necessarily going to get too deeply into, but I will say, as gynecologists, we're taught that women who don't have a uterus don't need progesterone. But it doesn't make sense because progesterone is good for our heart, good for our brain, good for our breasts. We just talked about all of that. So to me, whether a woman has a uterus or not, she still gets progesterone as long as it's bioidentical progesterone. So testosterone replacement therapy, it can be replaced in many different ways. Again, it's essentially through the skin. I don't really prescribe it as an oral. It actually just came out as an oral for men, which is very interesting. But for women, generally, I prescribe it either in a cream and injection or a pellet. Patches are not available in the US, but there is a commercial patch that got approved in, I think in the UK and maybe Australia. Anyway, a lot of people, I'm most happy with injections and pellets for my patients. Like I said, though, some of the worst cases I see of overdosing testosterone, I would say, are in testosterone pellet therapy. In the last several years, there have been a lot of gynecologists taking like a weekend course to learn how to do pellet therapy, and then they're replacing according to a computer algorithm. I think the algorithm is skewed much too high for both estrogen and testosterone pellets because you can get estrogen in a pellet. And that's where I've seen some of the worst side effects from bioidentical hormones. And unfortunately, they give the whole bioidentical hormone therapy world a bad name. So like I said, if you're going to do testosterone, you have to make sure that you go to somebody who knows what they're doing. But you know, I can always make suggestions if there's interest. So other ways you can raise testosterone, if you don't want to take testosterone therapy, there's a whole bunch of things here. Decreasing calorie intake, increasing protein in your diet, which helps to increase amino acids. You can take these particular amino acids of arginine, leucine, and glutamine. Getting more exercise, especially HIIT training and resistance training, making sure you get enough sleep, losing weight, losing fat, helps to make more testosterone. Reducing your stress actually helps you make more testosterone. And taking zinc if you're zinc deficient, and your doctor can do a test called an RBC zinc to tell if you're zinc deficient. And zinc's important for COVID these days too, as well as vitamin D, of course. So measuring hormone levels. I think it's advisable to use hormone testing to measure hormone levels. For me, it helps detect hormone imbalances, and it helps pair up the symptoms with the hormone deficiencies and imbalances. It can help establish a baseline prior to therapy, and then you can monitor levels while people are on therapy, and you can track treatment progress with those levels. A lot of doctors don't think it's essential. I think it's best, but not necessarily essential. So I'm going to wrap this up by quoting this study that was just released in February of 21. And if you don't mind indulging me, I'm going to read the whole thing because I think it's really interesting. Clinically, HRT is usually initiated near menopause. The WHI tested something different, as you now know. The effects of HRT started a decade or more after menopause. As it turned out, age at starting HRT is critical in determining benefit versus risk. HRT use plummeted following the WHI in 2002 as it has remained low, prompting strong interest in alternative treatments. They go on to talk about alternative treatments for a minute, but going back to what they were saying, HRT can provide effective relief for a wide range of health conditions, potentially avoiding the need for multiple treatments for separate problems, which is very true. And this is probably most important to me. Unfortunately, among many women and clinicians, the perception of HRT benefit versus risk is distorted, and its use has been avoided, leading to unnecessary distress. Following the WHI, many clinicians have not received adequate training to feel comfortable prescribing HRT. When initiated within 10 years of menopause, HRT reduces all-cause mortality and risks of coronary disease, osteoporosis, and dementias. I'm not sure really what else we could say. That pretty much sums it up, and I'm really glad that that's what they're saying for where we are now. That's what the article was called. So in conclusion, many benefits to hormone therapy: more energy, better mood, increased sex drive, better sex, relief from hot flushes, night sweats, better sleep, improved memory, better joint mobility, decreased risks of diseases. Thanks so much for spending this time to learn more about hormone replacement therapy. And I encourage you to continue to do your homework and don't let this critical timing window pass you by. Thanks, everybody.